Hello everyone. Today we'll discuss about neuroblastoma. Starting with the introduction, it is the embryonal cancer of peripheral nervous system. So, neuroblastoma, they are the embryonal cancers of the peripheral nervous system. Okay, and it is the most common extracranial solid tumor in children. So it is one of the most common extracranial solid tumor in children. It is the median age of diagnosis of neuroblastoma is made by 22 months of age. So median age of diagnosis can be by 22 months. It is most common in male compared to the females. Okay, so this is about the introduction of neuroblastoma. So they are the embryonal cancers of the peripheral nervous system, and it is a most common extracranial solid tumor in children. Next, going on to its pathology or pathogenesis. So going on to pathogenesis, the etiology remains unknown. So the etiology of this remains unknown, but 1 to 2% of the cases account for familial in origin. So they can be associated with familial. So what are the genes that can be associated with neuroblastoma? So the genes that is associated is, it is associated with mutations in POX2B and ALK genes. So it's associated with mutations in POX2B and ALK genes. And BARD1, and there is a BARD1 mutation. It is the major genetic contributor to the neuroblastoma risk. So it is the major contributor to the neuroblastoma. So the genes that you have to remember is POX2B, ALK and BARD1 genes. Next we'll go on to its prognostic importance. So the genetic characteristics that is leading on to its prognostic importance. So the genetic characteristics of the patient that is leading on to its prognostic importance. First, when there is an amplification of MYCN proto-oncogene that is associated with the advanced tumor stage and poor prognosis. So when there is when the patient has an amplification of MYCN proto-oncogene, then it is associated with the advanced tumor stage and poor prognosis. Okay, next, when there is a loss of heterozygosity of 1P, 11Q and 14Q, or when there is a gain of 17, or when there is a gain of 17Q, this everything will be associated with a poor prognosis or worse outcome. Okay, next, thirdly, when the patient has a hyperploidy, they will be having a good prognosis. So this is about the genetic characteristic and its prognostic importance. Next we'll go on to its pathology. So moving on to its pathology, we'll have gross pathology and microscopic one. So in gross pathology, they vary in size from in situ to a large mass that is weighing up to nearly 1 kg. So they vary in size from in situ to a large mass. Okay. On seeing it in a gross, there will be a soft lobulated mass. They can also have this foci of calcification. Okay, this is about its gross pathology. Okay, next we'll move on to its micropathology. So this is the micropathology. This is a slide. I mean, when you see the neuroblastoma in a slide, you will be seeing it like this. So there will be these are the neuroblastoma cells. So you will be seeing a small round oval cells, that have a scant cytoplasm. So that is having, I'll write it here, that is having a scant cytoplasm with a hyperchromatic nuclei. Okay, and so they will be having what is called as, specific to this neuroblastoma, is they will be having these homerite rosettes. So what is homerite rosettes? Okay, so the homerite rosettes can be found in this, in which these tumor cells, these are the tumor cells, these tumor cells are these tumor cells are concentrically arranged about a central space that is filled with the neutrophil. So what is called as neutrophil? That is arranged around a neutrophil. So this is called as neutrophil. So what is this neutrophil? So this neutrophil is nothing but, so these are the eosinophilic fibrillary material. So these are eosinophilic fibrillary material. Okay, so the homerite rosettes are nothing but, and the tumor cells are concentrically arranged around a central space that is filled with this neutrophil. When suppose these tumor cells are concentrically arranged, but when this neutrophil is absent, so when this neutrophil is being absent, then it is called as, then you term it as pseudo rosettes. Okay, the pseudo rosettes are also seen in the neuroblastoma. So this is about the micropathology of this neuroblastoma. So another one, what they are being stained. So other markers that are helpful for detection of this neuroblastoma are this immunochemical detection of neural markers such as neuron specific kinolase will be positive, can be demonstrated on ultrastructural studies of small membrane bound cytoplasmic catecholamine containing secretory granules. So the immunochemical detection of this is by using the stain, that is neuron specific kinolase, which will give positive for this neuroblastoma. Okay, this is about the pathology. So pathology, you have to remember it is, they have a small round oval cells which have a scant cytoplasm and hyperchromatic nuclei. The background will be this is the background. They will be having a eosinophilic background, and they will be having this homerite rosettes. You have to remember this one, that is the neutrophil, the tumor cells that is surrounding the eosinophilic, the fibrillary material, that is called as neutrophil. When the neutrophil is absent in that, it is called as pseudorosettes. It is homerite pseudorosettes. This is the pathology of the this neuroblastoma. Next we'll see its staging. Here we have a international neuroblastoma staging system. I'll write it here separately. In stage 1, there will be a unilateral localized tumor. So it will be a unilateral localized tumor with a complete excision. So you can do a complete excision with or without the microscopic residual disease. Plus they will be having ipsilateral lymph node. This ipsilateral lymph node will be negative for the tumor. Okay, this is stage 1. Next, stage 2A. In stage 2A, there will be a localized tumor. Okay, there will be localized tumor without a complete excision. It is a localized tumor. This is a complete excision. Here it is without complete excision. Their ipsilateral lymph node will be negative. Next, in stage 2B. In stage 2B, it will be a unilateral localized tumor with or without. Here it can be with or without a complete excision, but their ipsilateral lymph node will be positive for the tumor. Along with this, they will have contralateral lymph node will be enlarged, but it will be negative. It will be a negative for that. It will be only be enlarged, but it is negative for the tumor cells. Okay, this is stage 2B. Next is stage 3. In stage 3, there will be it can be of two types. Here they can be having a unilateral unresectable. They can have a unilateral unresectable tumor that crosses the midline. So that the tumor will cross the midline with or without lymph node involvement. Okay, or they can have a unilateral resectable. They can have a unilateral resectable tumor with a contralateral lymph node. Their contralateral lymph node will be positive for the tumor cells. Okay, this is stage 3. Next is stage 4. Stage 4 is metastasis. That is, tumor has been spread to distant metastasis like lymph node, bones, bone marrow and skin. Next, you have a special stage called as stage 4S. Here they will be having a localized tumor, but with the distant metastasis it has spread only to the skin, liver and bone marrow. This stage is more common in the infants less than 1 year of age. Okay, and they have a good prognosis. Here in this stage you can wait for a spontaneous resolution also. Prognosis. Okay, so this is about the staging of the neuroblastoma tumors. Next we'll see its clinical features. So the clinical features depends upon its site of the tumor. So 40% of the tumor will be present in adrenal medulla, while 25% of the tumor will be present in paravertebral region, and 15% can be present in the posterior mediastinum. So the signs and symptoms will depend upon the site and the extent of the tumors. So signs and symptoms, it will depend upon the site and extent of the tumor. So we'll see. Suppose if the tumor is present in the paravertebral region, then you will be having spinal cord compression. Okay, when it is present in the, when the tumor or extent of the tumor is present in the posterior mediastinum, it can present with the superior vena cava syndrome. Okay, it can also get arise from the superior cervical ganglion. Then we'll be having this Horner syndrome. Next, it can go to its metastatic spread. When there is metastasis, it can be either a local metastasis, the local region, or either it can be a distant one. So distant one, it is spread mainly through this hematogenous or a lymphatic spread. So you will be having the symptoms such as fever, failure to thrive, bone pain, subcutaneous nodules, proptosis, and ecchymosis. This can be present when there is a metastasis. The children can also present with opsoclonus myoclonus syndrome. So this opsoclonus myoclonus syndrome is due to the paraneoplastic syndrome of autoimmune origin. So these are due to a paraneoplastic syndrome of autoimmune origin. Okay. So these are the symptoms, clinical features of the patient presenting with neuroblastoma. Next we'll see its diagnosis, how it is being diagnosed. First, so there can be present as a single mass or a multiple mass. There can be a single mass or a multiple masses. They can be present in a plain radiograph or in the USG abdomen, you can find this, or in CT or through MRI. The tumor markers are vinyl mandelic acid and HbA. Okay, they can be present as excess in the urine in 95% of the cases. Okay, the tumor markers vinyl mandelic acid and homovinylic acid. Okay. Next, by pathological diagnosis, you have to take the mass for the tissue should be obtained for the pathology by biopsy. When you diagnose the child is having a neuroblastoma with the features, with the clinical features of metastasis, then you have to search for any metastasis by using a CT or MRI of the chest and abdomen. Bone scan can be done to look for any cortical involvement. Next, you should do 2 independent bone marrow aspiration or bone marrow biopsy to evaluate for the marrow disease. Okay, so you should be doing 2 bone marrow aspiration and biopsies to evaluate for its bone marrow involvement. If MABG is present, if you have a chance of doing this MABG, it can be done to define the extent of the disease. This can be done to define the extent of the disease, or if you have this PET CT, you can do PET with CT or MRI can be done to look for the extent of the disease. So this is how you diagnose a child having a neuroblastoma. Next we'll see its treatment. In treatment for the low risk patients, so who are all staged as low risk are, I'll show you the staging. Here here the stage L1 it refers to the stage 1, while L2 here, that is in the International Neuroblastoma risk group staging system. In this risk group staging system, L2 is defined as the patient having the stage 2A, 2B and 3 are staged as L2. Stage 1 is termed as L1. Okay. Well, for stage 4 is metastasis and stage 4S is MS stage. Understood? So when the child is being diagnosed to have a low risk, that is in the L1 and in the L2 stage, L1 and L2 stage, they can be doing a surgery. Okay. And this MS stage, you can wait for a spontaneous resolution. When they are being in a intermediate risk, this in L2, this in L2 with the stage 3 can be in an intermediate risk. So for this patient, you can do a surgery with chemotherapy with plus or minus radiotherapy. Okay. For chemotherapy, what are the drugs being used? Here they use cisplatin, cyclophosphamide, doxorubicin and etoposide, that is CCDE. Okay. Suppose if the patient is being in a category of high risk, that is with metastasis and all, in a high risk category, then you will be using an intensive chemotherapy with a high dose chemotherapy with surgery, and along with this radiotherapy. This high dose chemotherapy will be followed with autologous stem cell rescue plus you will be giving 13-cis retinoic acid. Okay. So this is the treatment options for a patient when the patient is having a neuroblastoma. So you will be categorizing as low risk, with intermediate risk and high risk, and MS will be a separate category, that is metastasis, that is spread only to the skin, liver and bone marrow, that too mainly present in the children less than 18 months or 1 year of age. Okay, this is about the neuroblastoma. Thank you. Next topic we'll cover it on other tumors, or we'll cover it on twin to twin transfusion syndrome. Okay, next topic will be twin to twin transfusion syndrome, that is for the newborn classes. After that we'll cover brain tumors. Okay, please like, share and subscribe my YouTube channel. Thank you.